Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. This is the Alan B. Levan Innovation Center, which is a combined element of cooperation between Broward County and Nova Southeastern University. And today we have a wonderful guest, Dr. Elys Perez, who is an endocrinologist with Broward Health, and we're going to be talking about something that you've asked us to talk about. Remember, this show comes from questions from you, the viewers. So, Dr. Perez, welcome.
Thank you. Thank you for having me.
And I know that you're particularly, of course, as an endocrinologist, it's a very broad field, even though it's a specific field. But you're going to talk about thyroid disorders, signs, symptoms, and treatments, correct?
That's right.
And like I said, this show is really a cause and effect by questions that come from the viewers. We're into our 23rd year, so we get a lot of questions. But recently, we've had an increased number of questions about thyroid disorders. So why don't you just take it from there and start to communicate as to some of the items that you're dealing with as far as an endocrinologist.
Sure. Well, once again, thank you so much for having me. And yes, thyroid disorders are very common. So I do see them quite frequently every single day during my practice. There's many different types of thyroid disease, but there are two very common ones, which are overactive and underactive thyroid disease. And these have different symptomatology that patients present with and can cause a lot of distress and lead to comorbidities, and they need to certainly be addressed. I can go over those diseases a little bit more into detail. There's also the question of thyroid nodules, which we're seeing a lot of, mostly because we have access to a lot of imaging studies. So whenever a patient goes to the ER for a particular complaint, they may end up with a CT scan or an ultrasound, and then they find a thyroid nodule, and then patients get referred to an endocrinologist to further evaluate that. So I think those are the most common types of thyroid disorders that we see. There are others less common, but these are the majority of the cases that we're having. And this causes a lot of anxiety sometimes and stress in patients' lives because there's so much information out there. And the symptoms of the diseases are sometimes non-specific, which means that many other diseases can have similar symptoms. But it's not until we actually get the blood test and the patient's symptoms correlate with those blood tests, that's when we can make a diagnosis. Symptoms alone does not allow us to make a diagnosis. So it's very important to tease out what's really caused by thyroid versus what's not.
You know, a lot of the questions that we get, of course, you see so many ads on television for different pharmaceuticals, and they talk about everything from bulging eyes to, I can go on and on and on, what they talk about. But the reality is that there's so many opportunities, I believe, and you tell me otherwise, for an individual to be referred correctly so by their family practitioner, by the internal medicine doctor, to have a scan and turn it over to an endocrinologist, because there are so many items of problematic, shall we say, involvement later in life that are really very, very harmful, if not deadly. So why don't we get into some of that with you?
Sure. So for example, we can take as an example overactive thyroid. So when a person has an overactive thyroid, that means that their thyroid gland is expressing too much thyroid hormone, and that makes the body have a higher metabolic rate. So what that means in terms of symptoms, the patient might experience palpitations or increased heart rate. The patient might lose weight rapidly for no apparent reason. They may feel like they have like a burst of energy at the beginning of the disease, but later on end up feeling fatigued and short of breath. And if this is left unrecognized or untreated for a long time, it can lead to something called thyroid storm, which is a very severe expression of this disease in which the whole body kind of tries to shut down and has a high mortality rate. And people need to be in the emergency room, and they get admitted, they go to the ICU, and their vital signs become abnormal. They may get nauseous, vomiting, all kinds of different symptoms. But the interesting thing about this is that patients rarely get there. They rarely get there because primary care physicians are, for the people that do follow up and go to their preventative appointments, with just one blood test, they can determine whether the patient has the beginning of this condition. And we can prevent. We can do a lot to prevent and to treat. But a lot of times, if left untreated, it can progress and it can have cardiovascular problems as well. Because when the heart the heart rate starts increasing, sometimes it can become irregular. And that irregularity can lead to atrial fibrillation and stroke, especially in older patients. So it can be quite dangerous when the thyroid disease is not addressed. Patient can also present with mood symptoms, which I forgot to mention, but mood symptoms can sometimes be very troublesome to patients. They can become depressed. They can have like a burst of energy and then all of a sudden feel really down and a lot of mood changes and not really know what's happening. So it's important that this is addressed, and the primary care physicians do a great job at catching this early because the patients will present with some symptoms, and this is a very easy screening test. But there are those cases that the patients get lost to follow up, or the patient may not take their prescribed medication or follow their treatment plan, in which case they could end up with complications from thyroid disease. And that's the case for overactive thyroid. An underactive thyroid has different complications that can occur.
You know, we had a program a while back with a very well-known psychiatrist, and one of the things that came up was, and I would like to know whether this is not, you know, whether it's not whether it's accurate, but I'd like to know the statistics right. That there's a tremendous amount of thyroid involvement with the psyche disorders. You want to talk a bit about that?
Sure. So thyroid disease, certain types of thyroid disease are more common in females than they are in males. And they can certainly occur at the same time as other psychiatric diagnoses. But I think maybe what the psychiatrist was referring to, which is very, very important, is that whenever you send a patient to the psychiatrist, or they've already had a screening test done by their primary care physician, but you should always maybe check a thyroid test, because thyroid disorders can have a lot of mood symptoms, and you don't want to confuse that with psychiatric illness. Patients may have both, and a lot of patients tend to. A lot of patients can present with psychiatric illness and thyroid disease at the same time, but you certainly want to address the thyroid disease because it will certainly make the psychiatric illness worse, whether that's hypothyroidism or hyperthyroidism can certainly make the illnesses worse, given that the patient has underlying disease. Now, we do need to mention that there are some psychiatric medications that do alter thyroid function, and there's others that alter other hormones. But that being said, we can treat the thyroid disease. The patient doesn't necessarily need to stop that psychiatric medication that may be working well for him or her. But what the patient needs to do is see an endocrinologist so that we can manage the thyroid disease, normalize it as the patient continues their therapy.
We also had, I'm sorry, I didn't mean to step on your words. We also had a program one time that we spoke about children, the so-called spectrum issues. And there was some comments made about thyroid deficiency. Have you found much in that area?
Not much, but I see adults, so I don't really get to see the child population. However, they always check for thyroid problems at birth. So it's unusual for little kids to present with thyroid disease. It's not very common. It tends to be older adults or young adults, and then the elderly population. But it's less common in children. That being said, I'm not aware or haven't read upon studies that screen for this in kids that have autism or are in the spectrum. I'm not sure what the correlation would be, but in general, at birth, every child gets screened for thyroid disease.
I'm aware of that. Endocrinology is an amazing subspecialty. I really think it's tied to so many different, shall I say, issues of illness, but yet issues of mitigating the problem. And particularly, you touched on the cardiovascular issues. Most of the times that we've had these communications with various colleagues of yours in different subspecialties, it seems to always have come up about the thyroid issues, particularly the issues relative to cardiac problems. So could we go a little deeper into that?
Sure. So again, with untreated disease, we see this, the both spectrums, the overactive thyroid and the underactive thyroid, they both affect the heart. So the overactive thyroid will make the heart beat faster, and the underactive thyroid does the opposite. So untreated for a long period of time, that can have an effect on the heart and can certainly weaken the heart. What we see more with patients that come into the hospital, for example, with atrial fibrillation that have a thyroid disorder, it's something that they've had and hasn't been checked or treated for a long time. Sometimes it's very mild and it doesn't really get repeated, or the patient gets lost to follow-up and they unfortunately end up in the emergency room with an increased heart rate, which puts them at risk for other complications. But I think something that's important to note is that a lot of these things can be prevented with appropriate treatment and adequate treatment. But definitely it puts a strain in the heart. Hypothyroidism, which we didn't really touch upon yet, but hypothyroidism, which is the underactive thyroid, that can cause a series of other complications for people. It can come from weight gain because they can gain weight. And if left untreated for a long time, it can lead to something called mixed edema coma, which is an endocrinologic emergency, also with a high mortality. Patients get depressed respiratory rate, the heart slows down, everything slows down, and these patients end up in the ICU treated right away to try to kind of bring them back. But both spectrum of the disease can cause high strain on the heart, for sure.
Yeah, and also we've heard relative to the subspecialty that you're involved in, that a lot of the trauma events, all right, that when they, of course, knowing that you're a level 1 trauma center at Broward Health, or at least the shall we say, Broward Health in Fort Lauderdale, and also Broward Health up on, I guess, in North Broward County. The issue of thyroid issues, either because of the accident or occurrence, but also you find it in individuals who have not been screened, and it leads to some real problems between the event of occurrence of an accident or something of that nature, and then when they get to the hospital. So how is that dealt with relative to working with the EMT paramedics and then getting them into the hospital?
Sure. So what they want to address first is the acute issue. The presenting symptomatology that brought the patient there, whether that's the heart problem, whether they're having a stroke, or whether there's other kind of symptom that they're presenting with. Whenever there's an acute event and somebody checks thyroid tests, they a lot of the time tend to be slightly abnormal. And it's up to the physicians to tease out whether that abnormality is actually causing the disease, or whether that abnormality is a normal response to the stress that's happening. Because the thyroid test can be a little bit abnormal under high periods of stress, and that's a normal response for the body. So it's important to kind of tease out what is what, because it will allow for better treatment, for sure.
The other thing that comes up often, and there's been questions, like I said, this program is driven by questions from our viewers. Obesity, unfortunately, is almost endemic. I can't really offer comment. I'm not here to offer comment, but you see the unfortunate occurrence of obesity growing at an alarming rate here in the United States. It is not only because of, you tell me, it's not only because of a thyroid disorder, but probably a intake of inappropriate foods. So how do you deal with that when someone shows up with a thyroid issue, but really it's cause and effect of improper nourishment?
Right. So I always counsel my patients. I think a lot of people, like you said, Dr. Lippman, they show up and they have these questions. The first thing is to get a screening test. And then I use that to show them, even if you have hypothyroidism or underactive thyroid, which sure, it can make it more difficult to lose weight. It might have made it difficult for you. It might have caused you to gain weight at the very beginning. But now that it's being treated and the thyroid tests are normal, there's no reason for this to be causing the excess obesity. So I counsel them a lot to take this out of the picture, because when the thyroid is functioning normal, whether it's treated or not, or you don't have a thyroid disease or you do, it is not the cause of the obesity. So that, I think patients require a lot of that counseling, because as soon as they go on the internet and they put obesity, the first thing that might show up is, thyroid disease. So it's important to educate our patients on what constitutes thyroid disease and what doesn't. And like you said, cause and effect. So somebody that might have had an underactive thyroid, they might have gained weight at the very beginning and then just have had difficulty losing it, and they may continue to gain weight for other reasons. But once that is treated, that weight is kind of out of the picture, out of the question, because the disease is well controlled and is treated. Another thing that I wanted to mention is sometimes in overweight individuals, we end up finding thyroid nodules, which can be also distressing for the patients. And they end up having different studies done, which when they come to me, they've already either have gone through the ER or the physician might have felt something. So these thyroid nodules need to be addressed because not all of them are, it's not an indication that you have thyroid cancer. And the majority of the nodules, in fact, are benign. And it's important that an endocrinologist looks at that thyroid ultrasound and makes the appropriate assessment to determine whether these nodules can be monitored or whether they need a biopsy or not. So that's also something that we see with more frequency in the overweight or obese population.
Well, I'm glad you brought that up because there was a question by one of our viewers relative to thyroid nodules. The thyroid nodules, whether they are positive or negative relative to cancer, are they removed surgically?
Yes, so when a thyroid biopsy comes back as positive for malignancy, we send the patient for surgery. And the type of surgery that they will have depend on the extent of the nodule. So if they have a small nodule just on one side, they can have a partial thyroidectomy where they remove half the thyroid. But if they have multiple nodules and one of them was malignant, then it's recommended that you remove the whole thyroid. So what ends up happening is if half the thyroid is removed, for example, and the disease tends to be more extensive once the pathologist looks at the actual tissue, then the patient would need to go back for a second surgery to remove the rest of the thyroid. But the extent of the surgery, they're always referred to surgery because that's the first step for thyroid cancer. And it has very good prognosis most of the time. So surgery is the initial approach, but the actual extent of surgery gets determined by the amount of nodules and where they are located, etc.
And after, this was another question that came, after a thyroidectomy or partial thyroidectomy, how is the patient is treated with simulated or direct thyroid pharmaceuticals?
Yes, so the patients will be placed on thyroid hormone. So if the patient gets a partial thyroidectomy, they may not require thyroid hormone. It all depends on the pathology. So if it's a small tumor, has low risk of low risk of recurrence, and the TSH is normal, then those patients tend to be monitored without further therapy. But if you have a total thyroidectomy, then you will need thyroid hormone replacement. And the degree of how much a patient needs depends on that pathology. Less aggressive tumors need less thyroid hormone. More aggressive tumors, we tend to keep the patients a little bit hyperthyroid. So we give them a little bit more thyroid hormone to suppress any remaining cells there. It's also important to note that for evaluation of whether a patient will need something called radioactive iodine, which is given sometimes after thyroid surgery for thyroid cancer, it depends on that pathology. Not everybody needs it. Some patients end up getting it, and the point of the radioactive iodine is to exterminate any other cells that are present that could be cancerous. And patients tend to do very well.
Okay, now let me just get back to something I touched on before. As an endocrinologist, do you work with a team of individuals that also participate in giving the patient, shall we say, advice relative to intake and nutrition?
Yes. So in terms of nutrition, so what I do with my patients, not so much my thyroid disorder, my patients that have thyroid disorders, but more my patients that have diabetes. I do refer them out to nutritionists and to diabetic educators because it's very important for them to get that education and support from them in addition to what they're getting from me. So it's always a team-based approach. The same in the case of thyroid cancer, for instance, where I communicate with the surgeon and the radiology team that's doing the radioactive iodine therapy. We all kind of work together to guide these patients, but they do need a multidisciplinary approach to kind of get them better in their disease states.
Okay, well, I think we've gotten a lot of good information. We're down to the last 2.5 minutes of this show, so I'm going to turn it over to you, and you tell me anything that you want me to tell me and the viewers relative to the field of endocrinology.
Oh, great. Thank you so much. What I would say to the viewers is make sure that whenever you're experiencing any symptoms, you check first with your primary care physician so they can do the appropriate testing. The primary care physician, once they do the appropriate preliminary testing, then they'll refer out to the endocrinologist, whether that's for overactive or underactive thyroid or from thyroid nodules. I would advise people to look at the thyroid.org website, which is the American Thyroid Association website, because everybody's going to Google their symptoms. So if Google is telling you thyroid disease, I prefer patients not to go that route and actually look at a good source, which is the American Thyroid Association website. There they can find most of the information about any kind of thyroid disorder and thyroid nodules and thyroid cancer, so that they can feel a little bit better and more prepared for the visit. And also not to get ahead of themselves. These diseases are very treatable. A lot of the time, these are autoimmune diseases that there's nothing that the patient did to get what they have. It just happens. So it's not their fault. It's not their nutrition. Not in this country anyway. In other countries, there's iodine deficiency, and that causes all kinds of other thyroid issues. But here in the United States, we have all kinds of foods. So we don't have iodine deficiency and things like that. So first, get a screening test. Check what you have, then go to the specialist to figure out how to best treat it, and make sure that you follow up. Once you get that initial treatment, make sure that you listen to the doctor and that you continue your follow-up, because these are lifelong diseases. So that would be my advice for patients, and thank you so much for having me.
Well, thank you very much. We're very pleased to have you on the show. As I always say to the people who are viewing, it's really your responsibility as well as the doctor's responsibility to make the doctors aware of your problems. Don't wait until there's a near tragedy. Don't go into a supermarket or a pharmacy and pick something off the shelf and think it's going to help you. You've got to talk to your physicians. And then if the physician has a relationship, properly so, with the indications that are presented, he will send on to someone like Dr. Perez, who will be dramatically helpful to you and save your life, and make your life better. So remember, people like Dr. Perez and other physicians are there to help you. They're not there just to be there with knowledge. This program is called Dateline Health. I implore you once again, talk to your physicians. My name is Fred Lippman. Until next time, see you.